Hi, Dr. Paul Lento from the Department of Orthopedics and Rehabilitation. With me today is Sal, our volunteer male model, so we wanted to thank Sal for joining us today. I've been asked to describe with you the upper limb extremity examination, screening examination, as well as the spine examination. Before starting out, though, with any physical exam maneuver, it's very important that you appropriately wash your hands. So I'm going to head over to the sink here. It's a good idea to use hot or cold water. Basically, you just want to try to create some mechanical disturbance so that you can clean the skin and prevent the spread of infection. So that's an important point. I think it also reinforces to the patients that you use proper hygiene prior to the examination, so I think that's another important point. When I get started for the physical examination, after I've taken an adequate history, I like watching the patient disrobe. So I'm going to actually have Sal in a male disrobe so I can really get a good look at his upper extremity, both function as well as anatomy. So Sal, go ahead and do that. In a woman, sometimes it's easier for a woman maybe to partially, obviously, gown them, so where they might have one hand in their garment and you can tie up the robe back like this. I also find that in younger female athlete patients that sometimes a training bra is helpful to do an adequate examination. But for Sal, being that he's a male, we're going to allow him to completely disrobe for the upper extremity examination. Before I also start, I just wanted to highlight some important planes of motion, which are all planes that we move through, and sometimes it's missed on examination. Particularly when you're describing this to a colleague, you can describe to them a particular plane of motion. The three planes that we highlight are the sagittal, coronal, and transverse planes. The sagittal plane is any motion that occurs in front of the body or behind the body in 90 degrees of motion. So this would be considered shoulder flexion, for example, or a sagittal plane motion. The second plane would be coronal plane, or sometimes referred to as frontal plane motion, and that's anything that's in the plane of the body. One way to remember that would be to look at the sutures of the calvaria. The sutures have similar names, so the sagittal suture would be one that's running directly down the middle of the cranium. The coronal suture, which is running in a 90-degree fashion to the sagittal suture, is another way to remember those planes of motion, so the sagittal and coronal. The third plane of motion is a transverse plane, or also goes by axial plane motion. That really involves any type of rotational motion. So if you talk about transverse plane motion through the spine or hips, it's kind of like your twisting motion, or if it's at the shoulder, internal and external rotation, which we'll highlight in a minute, also is a transverse plane motion. The next thing I do is, with any part of the physical examination in orthopedics and rehabilitation, is to start out with inspection. So we're going to start with Sal's hand here, and we're going to look at his nails first. With nails, you can pick up a few things that describe systemic pathology as well as arthritides. For instance, splinter hemorrhages sometimes can indicate subendocardial bacteritis. You could also have hemorrhaging, which may be from trauma. Also clubbing, which may result from pulmonary disorders. And then conditions such as I treat, which are spine conditions, pitting, such as in psoriasis, can sometimes lead to nail abnormalities. And psoriasis can lead to potential arthritides or different types of arthritis. The next thing would be to inspect the palms. And really, when we're talking about the palm, we're talking about the thenar eminence, which is on the radial aspect of the hand, as well as the hypothenar eminence, which is on the little finger side or ulnar aspect of the hand. So it's the hypothenar and thenar eminences. The next thing would be to look at the skin. And really, you're just looking for abrasions. For some patients, particularly patients who may be on steroids or those types of medication, they may have thin skin. You're looking for ecchymosis that may be associated with trauma. The other thing is to look at individual joints. And in the hand, we're talking about the distal interphalangeal joint, or DIP, the proximal interphalangeal joint, or PIP, and then you have the metacarpal phalangeal joint, because the metacarpal bone is this bone and the phalanx is this, so you have the metacarpal phalangeal joint, or MCP. So those are basically the three articulations of the fingers. You can move back proximally to the wrist, and you will have the carpal metacarpal junction, and these are filled with your carpal bones, and there's both a proximal and distal row. The other thing with looking about overall in terms of inspection would be to look for things such as fasciculations, atrophy, or any other types of deformities which may be important. Scars, which may have indicated previous trauma, as well as past surgical history, is also an important key point to check for. The next thing that sometimes that you would want to check in terms of hand examination and wrist examination would be pulses. And in the wrist, you have both the radial pulse, which is one that I think we're all pretty familiar with checking heart rate, as well as the ulnar pulse. And you can appreciate both of those. The ulnar is sometimes a little bit more difficult to appreciate as it sits a little bit more deeply. The next thing would be to pinpoint specific anatomic landmarks. And one of the most important ones in the wrist is what's called the anatomic snuff box. The anatomic snuff box represents one of the important carpal bones, which is your scaphoid. Sometimes that's fractured. Say, for instance, a young person who's skateboarding falls on their hand may fracture their scaphoid. And the way that you want to find this landmark is you want to have the patient extend their thumb. And basically what you're looking for is a little dimple that occurs on the dorsal radial aspect of the wrist. And it sounds not as prominent. I'll demonstrate on myself. It may be easier to see. You can see there's a little dimple that's created right there, and that's really the location of the scaphoid. And sometimes tenderness in that area may indicate, particularly in the setting of trauma, may indicate fracture. The next thing that we were going to go on to is describing different types of tendinous structures that may be present in the wrist. And on the volar side of the wrist, which is the palmar aspect, palmar and volar essentially mean the same thing, you want to look for different tendinous structures. So there are wrist flexor tendons that are on this side of the wrist, whereas on the dorsal side of the wrist, you will have the wrist extensors. The other important thing are looking for other bony prominences, such as the distal ulnar styloid, which would be on the dorsal aspect of the wrist, fairly prominent bony structure, as well as the radial styloid, which is on the radial aspect, dorsal radial aspect of the wrist. And you can palpate both of those structures. The next thing we're going to do is move up. Now, the elbow has very important articulations. It has basically a range of motion that basically has flexion, which is anywhere to approximately 130 degrees. You can have full extension, okay, which is, again, these are sagittal plane motions because they're occurring in this plane of the body. In women, sometimes they may be a little bit more lax and they might have increased extension through the elbow. They may have anywhere from -5 to 10 degrees. Not an important point, but something just to realize that women may be a little bit more lax than men. The important bony structures to also highlight at the elbow would be the olecranon process, which probably can be best seen by having the person bend their elbow. Clinically, this sometimes may be involved in terms of a traumatic olecranon bursitis. Somebody falls onto the elbow, may be developing some significant bursal swelling here. The other important structures are the medial epicondyle, which is the distal aspect of the humerus, which is here. This acts as the origin of the wrist flexors, and sometimes that's involved with what people euphemistically call your golfer's elbow, the medial epicondylar or wrist flexor tendons. On the outer aspect, you'll have the lateral epicondylar or wrist extensor structures, and you can palpate this as a bony prominence here. One other motion that's sometimes not described with the elbow, but more with the wrist, would be pronation and supination. Pronation I really think of as when the palm is turned down towards the ground. Supination is when the palm is turned up towards the ceiling. And you can really highlight this when you have somebody bring their palm up. Sal just demonstrated for us there finger extension, something I failed to mention in range of motion, and then finger flexion, which is, again, sagittal plane motion. If he opens his hand as such and he spreads his fingers apart, that's referred to as finger abduction. And finger abduction, B as in boy, is in reference to the long finger. So anytime you have coronal plane or abduction of the fingers, they are in reference is when he brings his fingers towards the third finger. So that's abduction away, and then adduction towards. So let's go back to the elbow joint. We highlighted a couple of things. Pronation, once again, palm down. Supination, palm up. You can see some of that motion occurs at the wrist. Some of that motion occurs at the elbow. Now we're going to turn our attention up to the shoulder joint. I think the shoulder joint is probably one of the most complex articular structures in the body. There are some important bony anatomy that we need to highlight. First would be the clavicle. And the way that I think most people are familiar with the clavicle, as we used to call it the collarbone, is just feeling the bony prominence that's sitting just above his pectoralis muscle. You can feel that and see it fairly prominently. And I typically will start palpating that and go medially towards the midline of the body. And this actually is what connects the upper limb to the axial skeleton. And this is through what's called the sternoclavicular joint. Sternoclavicular joint is located right about this area as you march your way along the clavicle to the sternum. As you march laterally, you'll come out to the acromioclavicular joint. The acromioclavicular joint is actually felt to be like a knuckle that you'll feel at the end of the clavicle. And the acromion is actually, if you think about it, and actually part of the scapula. So the scapula articulates with the clavicle, which articulates with the sternum, thereby linking the upper limb to the axial skeleton. Okay? The other important structure that's sometimes difficult to appreciate in a robust individual such as Sal here, he's a pretty strong guy, is the coracoid process. The coracoid process, the best way that I think to feel it sometimes is really to feel the acromion and then sometimes march your way down just below that area, maybe a few finger breaths, and you'll palpate in this area. You notice he winced because typically the coracoid process is a little bit tender to most patients. So it's not necessarily pathological, that's just sometimes the coracoid is tender like that. And again, in bigger individuals it may be difficult to palpate that structure. The coracoid is important because it acts as an origin for your biceps tendon. It's the short head of the biceps, and the long head of the biceps actually comes from within the shoulder. The long head of the biceps goes through two tuberosities known as the greater and lesser tuberosities. These tuberosities are very difficult to palpate in a lot of individuals. Once again, Sal has a very prominent deltoid, so it's difficult to appreciate that. One way that I find that it might be easier to feel is if you feel just below the acromioclavicular joint and move a little lateral. I sometimes put my hand in that area, and then I might have him just rotate his shoulder in and out. And sometimes you can feel these bony prominences a little easier. Again, they're very difficult to appreciate. The lesser tubercle is more medial, and the greater tubercle is more lateral, and in between is the long head of the biceps tendon. The other key factor with shoulder is talking about asymmetry, and one of the key factors with asymmetry is looking for atrophy. And frequently I will look at the atrophy of the shoulder of the deltoid, but more importantly is looking at the scapula. So Sal, let me just have you go ahead and stand up if you don't mind. And I'm going to have you turn around and face the wall for me.
Okay.